Welcome to the Network for Public Health Law webinar, Navigating Public Health and Democracy After the Election. The slides and a recording of today's webinar will be available within the next few days, and you will receive an email notifying you when they have been posted to our website. Feel free to use the Q&A function throughout the webinar if you have questions, and we will try to get to as many of your questions as possible. With that, I will hand it off to today's moderator, Darlene Huang Briggs.
All right. Welcome, everybody. I am going to give us just another few seconds for folks to join. Good afternoon. Guess good morning, probably for some folks as well. Maybe good evening, depending on if you're maybe somewhere else across the globe. We are excited to have you all with us. And as my colleague Kayleen said, my name is Darlene Huang Briggs. I am the Deputy Director here at the Network for Public Health Law. Let's see here. I want to make sure are other folks able to hear before I keep going, because I see one comment and don't want to keep going without others being able to hear. Okay, great. All right, we'll keep going then. We're heartened to see many of you with us today. That's me. My work here at the network is to support public health practitioners with law and policy guidance. And I've been working on projects related to protecting and improving the public health system as a whole, so we can all better fulfill our mission to protect the public's health and advance health equity. And I'm glad you can hear us now, Nina. Before I officially get us started, I want to get through some other logistics. So let me just briefly introduce you to the other speakers you'll be hearing from via slide. So if you can advance to the next slide, thank you. This is the order you'll hear from them. Nora Maz is the Health and Democracy Coalition Advisor at Institute for Responsive Government. Spring Schmidt is the Executive Director at the Missouri Center for Public Health Excellence and Director of the Office of Public Health Practice at St. Louis University College for Public Health and Social Justice. The network has enjoyed working with both Spring and her staff at MOSIFI, as well as with Nora and Jean, who made up Healthy Democracy, Healthy People. And we're thrilled when Nora introduced us to our third speaker today, Ashish Sinha, Chief of Staff at the Institute for Responsive Government, the new home for Healthy Democracy, Healthy People. Next slide. So here is our path for today. I'm going to start with some important acknowledgements and level setting around public health authority and advocacy, which have been and will continue to be important foundations for all of the work in the field of public health. Nora will draw out more specific connections between health and democracy, and Spring will share how they've been navigating the various tensions within government that impact public health's ability to meet the need of Missourians. You'll either love or hate me for making you wait until the end to hear more directly from Ashish about reflections from the election more broadly, and what that means for all of us moving forward. So next slide. This is the last bit of housekeeping. This is the disclaimer that our work at the network is educational in nature, but it is not legal advice. If legal advice is what you need, you will need your own counsel. We do hope, though, that the resources and information we provide are helpful insights for you and your work. Okay, next slide. So with the significance of this year's election, I have been feeling quite on edge for a lot of the year at this point, and that has only heightened for me since the election and election night and the early morning hours in which we learned of the outcomes much sooner than I think many of us had anticipated. So that edginess is why you're seeing an image right now of Qing Bao, one of the giant pandas that will be making their public debut at the National Zoo in DC in January. The pandas have been not even a little bit, a lot of joy and playfulness and serenity for me. And so I wanted to share a short clip of some of that in hopes that it might be a little respite for you too. As Kayleen gets that video playing, I'd also like to invite you to introduce yourself in the chat box, including where you work and the location you're joining us from. And if you're so inclined, what, if anything, you may be grateful for in this very moment right now. All right, Kayleen. Right. Thank you, Kayleen, for that. And everyone who is participating in the chat box. It's nice to see so many of you that we have seen before in new names and locations and organizations. I can't keep up with the chat box, but I hope during the discussion, you'll also feel free to chat with one another and make some connections here as well. So, I asked you if you were so inclined to share what you're grateful for in this moment, and I think this is the way I'm going to start the discussion today. I am very grateful for each and every one of you and all the work that you do. Monday is actually the American Public Health Association's annual Public Health Thank You Day, so I'm wishing you all a thank you day early. I think it's important we start here with reminding you that the work that you do is valuable and incredibly fundamental to keeping all of us safe and healthy so we can be engaged citizens helping one another. I also think it's important to start here because many of you may be feeling similar to me, trying to make sense of whether you're living in a country that values you, your friends and family, your work, women, immigrants, the LGBTQ community, people of color. The list goes on. We also know that others may be feeling more hopeful about the more immediate changes to come, and both government and public health are about the collective we. That is the power that we hold. And so during a time where the chaos around me has been a lot, I am working very hard to hold space for more than my own truth and perspective here. So again, thank you all for the work you're doing. Next slide, please. So we definitely cannot deny that at the federal level, especially, the public's health is in jeopardy. As a field grounded in science and continual improvement based on the facts and evidence that guide our work, we know that mis and disinformation to sow doubt, division, and chaos doesn't help anyone to feel or be safer and healthier. So I'm highlighting here the U.S. News commentary from the former CDC official and current CEO of the Robert Wood Johnson Foundation, and the statement from APHA's executive director, because they're one good reference material and framing material for many of you with all the questions that you sent in regarding the new HHS secretary nominee. In particular, and I know, there's a lot of other commentary out there that's great, but in particular, what I want to do is highlight a couple of things that Dr. Rich Besser wrote, that this nomination comes at a perilous moment as trust in the government and public health agencies plummeted during the pandemic. So he notes that the hard work of building back that trust is ongoing and will take time, regardless of which party controls. But that person leading HHS must set an example by supporting science and always speaking the truth. And of course, the question then becomes whose truth? Next slide, please. So my answer to that question is our truth as the field of public health. Protecting and improving the public's health is necessary to a thriving economy and free and fair democracy, and we cannot back down from the power of the collective. In fact, we have to insist upon it more intentionally and strategically. And part of the reason I'm so glad we're doing this webinar is to help our field know that we are not alone and do not have to remain invisible. The reality is that our work, especially since the pandemic, has been and is front and center stage, and the opportunity is ours to seize. With rest and rejuvenation, of course, whenever we need it, because there's no doubt that the upstream systems level work that we've all been doing for a long time and will continue to need to do can be slow, daunting, and easily swept aside as too complex. Next slide, please. If you're looking for resources to help you make the case for public health, I wanted to point you in the direction of this framing and messaging work from Berkeley Media Studies Group, which our friends at Change Lab Solutions help make possible through the Act for Public Health partnership. I'm going to share some about that partnership in just a bit. I'm going to do that as a way to remind you that public health has undergone some version of what we're likely to experience over the next few years. Much of it will be actually reference material for you once the slides are available. So it may feel a little bit like we're jogging through some of it, but I will spend a little more time on the pieces that I think will be helpful to you all as context for what Nora, Spring, and Ashish will talk about. So next slide, please. For those of you not familiar with Act for Public Health, we are the 5 public health law organizations you see on the screen that, with funding from the Robert Wood Johnson Foundation in 2021, came together to address the challenges to public health authority in state legislatures and the courts that intensified during the height of the pandemic. The politicization of public health is fundamentally about the role of government. We support health departments and public health advocates navigating these challenges. And while much of our posture has been defensive in nature, meaning battling back rollbacks or making them less bad, we have also been working toward a more proactive approach as well. We will now have to hold more space again for the challenges. Next slide, please. From a law and policies perspective, these are the tensions that we're all going to experience and have been experiencing. We talked about the U.S. Constitution's framework for the varying levels of government and their legal powers on the left there and how they interact among the 3 branches of government on our webinar last month. So if you want more details, you can actually watch that playback or explore the Public Health Law Academy materials, which you can click to once you get our slides. But for today, what's important to know is that the source of the federal government's authority is generally limited to express enumerated powers in the Constitution. Over the years, the U.S. Supreme Court has found many implied powers as well that are not expressly listed in the Constitution, and both express and implied powers can and are shared with states, territories, tribes, and the local governments that states create. The conflicts between the use of concurrent powers by the various levels of government is where things get complicated quickly. But again, for the purposes of today, knowing that the courts are ultimately the final arbiter of those conflicts is key. So our contributions to the discourse about both the powers of the federal government and other more local sovereigns, and the composition of judges and justices that make up the courts will be incredibly important moving forward. Next slide, please. So what is public health authority then? This is the non-legalese version, which you can find on the Act for Public Health website. From a legal perspective, though, the U.S. Constitution, under the 10th Amendment, reserves all powers not explicitly delegated to the federal government to the states, and by extension, local governments. So this means that state and local governments have expansive authority to protect and promote the public's health, so long as actions are reasonable and balanced against the legal rights of affected individuals. Next slide, please. So that reasonableness and balance of the uses of public health authority are what came under fire during the pandemic. These are a couple of the early reports that the network released that actually may have more salience now, given the election. They describe a very clear, coordinated attack by the American Legislative Exchange Council, or ALEC, and its allies to outright prohibit or shift or limit fundamental public health powers, and more generally to upset the balance of those powers for the collective good with individual liberties. So these efforts happened across the country and were successful in rolling back public health powers in over half of states. Think bans on employer vaccination requirements or mask mandates, as well as blocking the use of business closures or quarantine, and shifting powers from the executive branch to the legislature for decisions that require public health expertise. Next slide, please. If a visual and interactive depiction of some of these laws is more helpful to you, Temple University's Center for Public Health Law Research is a fantastic resource. This is one of their more recently updated data sets of laws that were enacted, but they also have a number of data sets where you can click around and see state legislation that was introduced but not enacted too. So to get a sense of some of the concepts and issues that might be coming down the pike again. Next slide. The other legal tracking being done through Act for Public Health is related to court decisions that impact the scope of public health authority and the constitutionality of certain uses of it. Our colleagues at Northeastern University's Public Health Law Watch lead that work. And next slide, please. I imagine if it's not already been in one of their case updates, you will actually maybe see this one soon. This is one that my network colleague Emma Kaiser shared about this. She shared this case on our last month's webinar as well. And at that time, we were still waiting on a state Supreme Court decision to the Court of Appeals decision that found an emergency powers provision in Michigan state law to be invalid. Now, over 3 years since the COVID order was issued and challenged in court, we actually have a very important public health win in the courts. And so I'm inserting this here to just say we can do this, guys. We have seen this playbook before. We know what's coming and we can do this. Next slide. The other part of Public Health Law Watch's work that is exciting and daunting, again, holding some space for more than one thing at a time, is beginning to track what's happening in the courts at an earlier stage than when courts issue decisions. The decisions help us learn what we have to do differently now, but an early warning system would help us get ahead of those challenges to be more intentional and strategic rather than the usual defensive posture that public health typically finds itself in. Next slide. So if you're looking for short and succinct fact sheets, this is a good starting point for drawing the different threads I just talked about together. Change Lab Solutions has great ones like this that make the case about the importance of local public health powers and which are delineated in state statutes and regulations and for sure ensuring a safe and healthy society. Next slide. If my mention of regulations just now was like, how is that different than a statute? Our friends at Public Health Law Center also have this good, relatively short primer on the structure and functions of state and local governmental public health and their sources of power and ability to make binding law. Next slide, please. So one of the network's contributions to Act for Public Health has been searching for the bright spots or innovative laws and policies or uses of public health authority that are helping to shape a more effective and equitable public health system. We collected a bunch of them and they're in this report categorized in the ways and the areas that you see on the outside of that honeycomb. Things like data and public health system modernization, full of government approaches to advancing health and racial equity, workforce investment, and so on. It's a good grounding for beginning to articulate a unifying vision for public health and how we can then translate that legally into new and improved forms and uses of public health authority. Next slide. So that brings me to the framework or roadmap for more effective, equitable, and community responsive public health authority that Act for Public Health is working to build. This is being done by our partners at Change Lab Solutions. Building off of all of the work today to unify the field, we're working to answer this central question about the contours of legal authority needed for governmental public health to do its job well. Our thinking is related to the core activities of process, accountability, and outcomes. And so we're working to identify more examples, both old and new, of both authorizing legal mechanisms and the broader community context that supported their creation and use. Next slide. We'd welcome your continued participation in that discussion. So this is the Acton Public Health website where you can sign up to get more information on the collaborative's work. And then that QR code is to more directly fill out the form to get involved in the framework discussion. I'm going to leave this up for just a little bit because what I want to pivot to next is just a little bit about a related initiative that's all about what the added value of this information is besides educating ourselves. And that is our field's capacity to engage in effective advocacy. It continues to be one of the areas that most public health professionals want more training and need more skill building. So next slide, please. That's where the Fighting for the Public Health Initiative work is important to highlight. To actually defend or effectuate changes to the laws that shape so much of our work and the health of the public, there's an infrastructure that is needed to do the advocacy work in legislatures, with the executive branch, and in the courts too. So on the left is an image of 3 reports that have come out of this initiative, and I'd encourage you to at least thumb through them to see what resonates with you. One of these reports was a 50-state scan of the state of public health advocacy that shared themes across the states. And most recently, there on the right is the release of each individual state scan, because we know there are unique considerations and organizations in each state. And so we hope those will be helpful to you to get to know your advocacy partners and opportunities a little better. Next slide. I also just want to leave this slide up for a little bit, and maybe we can come back to it in the Q&A with our speakers. But I think this graphic from the Fighting for the Public Health Initiative really does a nice job of holding space for more than one truth at a time here. Each one of these tensions could probably be its own webinar. And I think you'll actually hear Spring in particular talk more about some of these tensions. Next slide. So this is, in my view, the job ahead of us for public health. We have been making progress towards each one of these opportunities you see on your screen, and we will continue to do so. The pace may be a little different now, and I, for one, will definitely be trying to unplug as much as possible next week. And one of the ways I will be doing that is reading with my son, Kyler. So next slide, please. This is what I'm going to end with. These pages are from the book, Baby Loves Democracy. And as I've been thinking about how I talk to him about my work and all the added extra dinner time conversations that he can't quite understand, but can feel the tension around, this is what I keep coming back to. It's got a few of the very important role models and key decision makers for public health and democracy that illustrate what I think is most important at this point. Inclusive representation that reflects the diversity of our collective communities, so our government and public health systems work better for all of us. And with that, I am going to transition it to Nora to take you through some of the more specific connections.
Yeah, thank you so much, Starlene, and thank you to the network for hosting this really important conversation today. My name is Nora Moss. I am the Health and Democracy Coalition's advisor at the Institute for Responsive Government, and previously served as the Partnerships Director for Healthy Democracy, Healthy People, which just moved over to the Institute for Responsive Government about a month ago. So excited to talk to you about health and democracy today. Next slide. So to just get us started, I just want to remind folks, and I always start with this reminder, that health is always on the ballot. We may see health on the ballot in really direct ways. When we see ballot measures or referendums that we can vote on related to like Medicaid funding or transportation access or smoking cessation programs, right? That is really clear that health is on the ballot, but health is also on the ballot when we are voting to elect our government representatives who are tasked with making the policies that influence health and the social determinants of health broadly. So we know that healthcare access is on the ballot, climate resiliency, maternal and infant health, reproductive health, public health authority, and everything in the social and structural determinants of health are really on the ballot in every single election, from local elections all the way up to the national one. Next slide. In 2020, I don't think sorry, everyone. The joys of working from home. In 2020, Healthy Democracy, Healthy People came together as a coalition of 11 public health organizations, really aimed at assuring that public health came out with a unified voice, saying that while the pandemic was really ramping up, it was still important for us to vote and participate in democracy, and communicated ways for folks to vote safely and keeping themselves, their families, and their community safe while doing so. Since then, we've done a lot as a coalition to promote and expand the public understanding of how health and democracy are interconnected, and I'm excited to walk you through that a little bit more today. Next slide. So yeah, how is democracy related to health? Next slide. We see health and democracy as interdependent, which is confirmed by research, and I'll get to that in a bit. But the short answer is that higher civic and voter participation is correlated with better health outcomes for people and communities, and lower civic participation is associated with worse health outcomes. One rationale for how voting is tied to health is through the understanding of power being a root cause for influencing policy that can advance health and racial equity. Next slide. So for us, I think it's important that we have a similar understanding of the definition of power. And I like Dr. Martin Luther King Jr.'s definition, which is power, properly understood, is the ability to achieve purpose. It is the strength required to bring about social, political, or economic changes. In this sense, power is not only desirable, but necessary in order to implement the demands of love and justice. And so we can see civic and voter participation being key to building collective power across and with our communities. Next slide. One way power manifests is through civic and voter participation. In a democracy, we can directly influence policies when we vote on ballot measures like funding for parks, education, transportation, like I was saying earlier. And we also vote on elected officials who are tasked with representing our interests in the policymaking process. Therefore, whose interests are reflected in these policy decisions is often tied to voting. And the policies that either enable or hinder community members to participate are key for advancing healthier, thriving communities. And historical and contemporary research confirms that when we have higher rates of civic and voter participation, communities are healthier. Next slide. Thus, bringing us back to this first slide kind of framework circle, healthy communities are also more likely to have higher civic and voter participation, making this a continuous and virtuous cycle. We also know that the opposite is true, where communities have less civic and voter participation, which is often due to governing structures that make it harder to participate. Those same communities have less power to influence, which reinforces worse health outcomes because the policies do not reflect the needs of the communities. Thus, this feedback loop can reinforce health inequities. Next slide. Some historical examples in research that confirms this and shows that whenever we have expanded the electorate or worked to ensure our democracy is more inclusive, we have seen improvements in health and the social determinants. For example, when women gained the right to vote, They were able to use their influence to ensure legislative bodies were more responsive to women's concerns, which led them to make investments to improve maternal and child health. Studies show that child mortality rates declined because of this. And while this table shows steps forward, we know that each step forward has been met with contention. And so we can't sit out as public health professionals and achieve our aims. And so we have to engage in this constant, continuous struggle for power with and in partnership with our communities. Next slide. So in 2021, Healthy Democracy, Healthy People was really ready to celebrate because in 2020 we had the highest rate of civic and voter participation since like 1900, and we saw no COVID outbreaks from that increased participation. But we realized we weren't really talking about that publicly or on the national scale. And so our coalition came together to tell the story of how health and democracy are interconnected. And when we did that, we realized that there were some gaps in the literature. We were looking currently in 2021, the literature covered historical examples like the ones I shared in my previous slide and international studies. And there hadn't been much research at the state level in the US with contemporary data. And so we did just that. We compared 12 public health indicators and the restrictiveness of voting policies in each state. The findings were incredibly clear that states with more voting access and greater civic participation had better health outcomes. Next slide. And so you can see here, this is our main findings slide. For those of you who are data nerds like me, each box on this slide is a state. And on the x-axis, we have states with less voting access on the left and states with more voting access on the right. And then on the y-axis, or the vertical axis, we have America's health rankings, state overall health. And you can see as you go up, states have better health, and as you go down, states have worse health. And what I see is a really clear linear relationship where states with more voting access have better health, and states with less voting access have worse health. Next slide. And while the Health and Democracy Index was one of the early pieces of evidence showing this relationship, it's been replicated and published in peer review articles. We've seen research confirm that where it's easier to vote, we are more likely to have better rates of state level health across time, across a 25-year time period, lower uninsured rates, and folks who are most likely to face voter suppression and be uninsured, so young people, low-income people, and communities of color are more likely to be insured than in states where it's easier to vote. We have lower working age mortality rates in states where it's easier to vote, and counties in those states had lower pre-vaccine COVID case and mortality rates. We also know that civic engagement, including voting, among young people and adolescents is positively associated with future income, education levels, and mental health compared to non-voters. Next slide. And so our coalition really worked with folks at Healthy People to encourage them to use and create a core objective that names increasing the proportion of voting age citizens who vote as a core objective under our 2030 framework. And you can see right now that it's currently marked as getting worse. And so that should be a call to action for everyone in the health sector to be doing what we can to promote an inclusive representative democracy. Next slide. We've also seen states adopt civic participation in their state health planning documents, like Minnesota, for example, added civic participation to their state health assessment earlier this year. And you can see that currently at the state level, at the aggregate level, Minnesota has had 61% of eligible voters vote in the 2022 midterm elections, which is the highest voter turnout rate in the country. But as community organizations engaged with the health department and asked them to look a little bit closer at disaggregated data. You can see on these graphs next to the civic participation objective that there are actual disparities across the state. So the health assessment includes disaggregated data on voter participation by race and ethnicity, income, age, gender, and geography. Next slide. And similarly, Wisconsin State Health Department also has included voter participation in the State Health Improvement Plan as part of their section focused on social connectedness and belonging. So there are various state and national health organizations and health departments who validate that there is a relationship between voter participation and health. And we're excited to see this kind of initiative and work expand across the country. And now I will hand it over to Spring to talk a little bit more about their work in Missouri.
Thank you so much. I really appreciate it. So my name is Spring Schmidt. I am the Executive Director for the Missouri Public Health Institute, also known as the Missouri Center for Public Health Excellence. And I also have the awesome opportunity to be the Director of the Office of Public Health Practice at St. Louis University in our College for Public Health and Social Justice. So I am a public health practitioner for most of my life. Including spending several years at the St. Louis County Department of Public Health and a stint as both their deputy director and director. And so local public health in particular is my life and primary passion, and getting to work on that at this point in my career to lift as a system and look at local public health issues has really been a privilege. So if you can go to the next slide. I already talked about this, and spoiler for the impact of local public health, but we do make some distinctions, I think, in this organization between governmental public health and the rest of the broader public health system. There's a lot of topical overlap in many of the issues that we take on and with many other types of organizations in the field. But governmental public health, especially at the local level, has some very different opportunities and constraints and responsibilities that are not always replicated in other parts of the public health system. And I think that's something that plays out particularly when we talk about the impact of politics and national conversations and media and elections and what the impact looks like for our local agencies or our governmental agencies in particular. Being a function of government, our local and state health agencies have been part of and influenced by politics and political leaders for really all of their existence. That is certainly true in Missouri. We have persistently had a fairly complicated political environment that we have operated in. These agencies are always governed by elected officials. They have budgets that are passed entirely through political processes. Those budgets become the policies of their jurisdiction. They play a role in enforcement in state and local policies, rules, regulations, et cetera. And so there are a wide variety of the political connotations that exist for our governmental public health agencies that aren't always top of mind, I think, in some of the broader public health conversations that we have that result in some of their own complexities. The local public health agencies are also drastically underfunded and understaffed, which is true across all of public health, but it has also been true for a long time and across really several decades at this point. In terms of knowing that our public health system has had those fault lines in it relative to funding and staffing in particular for the services that we provide. Next slide, please. Our government agencies, though, also have a different relationship sometimes with the public, especially at the local level. They have a very unique role that they play in community trust because they are so often very accessible and expected to be accountable to the public in some very personal ways, up to and including citizens, elected leaders, organizations in their communities, engaging with them directly, especially when they're angry. But also when the community feels like they have an unmet need or they have an experience of an unfair outcome or not being able to receive services or there's something else that they want to see be different. The public's ability to directly engage with local health agencies means that sometimes, especially when there's different agreements, confrontations happen persistently at that local level that have political connotations for those leaders all the time. Our local agencies rely really heavily on personal relationships, and often those relationships are interpersonal and specific to individual people. They rely a lot on familiarity with their services in order to drive the public's trust in the delivery of those services and in the consistency and delivery of the education and the messages that they have. There have been a fairly interesting number of polls that have talked about a general sense that the public is more likely to trust local officials. That's certainly been true in Missouri and a couple of other states around the country as well, that they are more likely to trust local public health officials when they are familiar with their services than they are to trust sometimes state or even national level leadership. That is helpful sometimes to local leaders, but is also a lot of pressure in that it can make it complicated to further back up local decisions or local trust in science or local expectations about what should happen in public health with additional organizations like the CDC or other national organizations that are frankly not as well trusted by the public sometimes. That frankly was true in Missouri before COVID. It has been even more true since COVID. And continues to be, I think, a complicating factor for the kind of environment that our local agencies are operating in. The trust from the public is very much always a two-way street. It relies heavily on a lot of communication and a lot of direct experience with the delivery of services. Those local agencies that are out there can't possibly compete from a communication standpoint with national conversations. And the amount of mis and disinformation that is available from all kinds of sources only makes that more complicated for local leaders to try to engage directly with the public about services that are necessary. When talking about the ability to perform maternal child health services, and talking about prevention of chronic and communicable diseases, and talking about opportunities for vaccination or how you can prevent injury, all of the other like myriad things that our local health agencies do as services really become complicated by that national conversation. And there isn't any way for our local agencies, I think, even if they had a wild amount of staffing and funding, it would still be difficult to out message some of these national conversations. And that presents just a really difficult picture for those officials to operate in. But I do think that we have seen that be mitigated in many of our areas in this state by really direct community engagement. Again, that familiarity with those local public health services can be a powerful mitigating factor in some of those conversations. We have an overall, I think, crisis of trust in public health in this country. It is coupled in many ways with a crisis of trust in government. I really appreciate the tension slide that Darlene showed earlier, because I do think that is very much the present reality that many of us are working in. I think all of that, though, was trending well before COVID. COVID made it worse and made a lot of things more plain within that space. But the localized delivery and communication of quality public health services, we honestly think is one of our strongest paths forward for trying to rebuild that trust in the public. If familiarity with direct service delivery is an influential factor on the opportunity to be trust or to engage in a trusting conversation with the general public. We do think the national landscape has been making that more difficult for a very long time. And social media and national media attention to some of these topics has also been making that a lot more difficult. If we could go ahead and skip to the next slide too. I wanted to give a little bit of context for Missouri if you are not from Missouri or not necessarily familiar with it. But some of the context that we operate in, Missouri is a relatively large state. I think we're the 18th largest in the country, but we tend to be in the lowest quartile rankings on a large number of almost all, fortunately, of our health outcomes. We particularly have some significantly inequitable gaps in our rural counties in Missouri, of which we have several. And among historically underserved populations in our heavily urban areas or across the state. And so we have a lot of inequitable access to care. We have some significant tensions related to that urban-rural divide, related to the delivery of services and the availability of resources. And frankly, our environment has been politically complicated for a while. And that has just been a reality that every local official and state official in this state has had to navigate amongst. We have had additional closures of rural hospitals in particular. We've had primary care reductions across this state, particularly in maternal child and OBGYN care across our state. As I said earlier, like the increasing distrust in government as a whole, also increasing distrust in other institutions that we might be able to look to rely on to back up the decisions that we make, or to reference for decisions that we might make, or recommendations that we make to our communities, has been a much more complicated picture. I think anybody in Missouri will fundamentally know that we can't quote a lot of public health sources that might be from, well, I'm sorry, but any place that is located on a coast in America is generally not considered an acceptable, citable public source for some of the decisions that we make. That makes our lives complicated on a lot of levels. It's difficult to quote and follow advice from the federal government, or to cite that you're following advice from the federal government, because the opportunity for that to result in direct pushback from local elected officials is high. And that makes our jobs more complicated as well. Because we have such a wide variety of decentralized infrastructure and a wide variety of leadership across the state, it means that we have a wide variety in the authority, and both the perceived authority as well as the very real authority that our local health officials have, including over what their public health responsibilities are, and how the services are delivered in their agencies. To talk a little bit more about that, we can move to the next slide. So I know there are a lot of states out there that are home rule states. Missouri very much is one. In those 115 jurisdictions, it's complicated by the fact that many of those agencies rely predominantly or operate off of our statewide rules and regulations. But may also have some additional rules and regulations. I want to give this moment for a huge shout out for the Network for Public Health Law for working with us on creating a Missouri toolkit on public health authority. As you saw before, we are one of those states that did also have restrictions on public health authority that was passed post-COVID, or actually we're in the middle of COVID. We have also had some very complicated court cases that have been difficult to interpret, and how that affects our ability to rely on public health authority to act in the public's interest and perform some of those services. So very much appreciate NPHL for their work with us on that. Those state rules are further supplemented by a wide variety of additional local statutes and authority. Local controlled government environment influences the leadership of the agencies. It influences local funding. It influences pass-through funding from the state, federal grant opportunities, your ability to participate in them, additional regulatory responsibilities, your ability to communicate to the public, how freely and without restraint you can communicate to the public, and certainly heavily complicated political environments that move far more quickly in some cases. And in that environment, our local officials are trying to perform basic services of public health and be trusted and develop those relationships. So frankly, I think it has been a complicated environment that we've been operating in for a very long time. We have currently, and have had in the past several years and prior to that, agencies operating with fairly hostile elected leadership. The majority of our agencies are governed by boards of health and are standalone governmental agencies with independent authority of broader government institutions, even within local or county jurisdictions. We've had local elected boards that have become targets of anti-public health activists that are determined to reduce the delivery of public health services, or are determined to place ideological constraints on the activities of their health departments. On the countryside, which is also not easy to deal with either, we've had increasing pressure from local officials to increase services, to continue to provide additional services or more complicated services, certainly a lot more clinical services, and other things that are relative to the public's need without actually increasing any funding to go along with it. I know that I don't think there's any local or state agency that is unfamiliar with the unfunded mandate in public health, and that makes the situation more complicated as well. We have agencies that are also, though, operating in the midst of all of this other tension with very strong local networks, with strong collaborations or partnerships with their boards, regardless of ideological constraints or ideological issues, that are focused on implementing high quality services, that are focused on investing in their agencies, that are building and not just tearing down. And so we have all of these things next to each other, side by side in communities across the state. And those communities are not based on size, and they're not necessarily based on voting patterns either, but are heavily, as I said earlier, based on the relationships that are being generated in those local areas. And so raising local funds, pushing innovative programs, all of those successes are happening like hand in hand with all of our failures to be consistent, to support this workforce, and to move some things forward based on science and what we know. Ultimately, what it means we have in Missouri is a system that is fairly chaotic. It is also fairly incomplete, and it varies widely, unfortunately, from location to location. I know we're not alone in that. If we can move to the next slide. Some of the other things that we have done that are about the environment that we've been working in and the things that we have been working to fix our system, to address our systemic challenges in Missouri, have been focused around our efforts to round foundational public health services. So we built a Missouri model for foundational public health services through a process that's called Healthier Mo. And this was a grassroots initiative that was funded by some of our local funders, that was advanced by some of our academic institutions and statewide associations, that was had grassroots participation from LPHAs across the state, that was very focused on really understanding and creating a model for what those foundational public health services needed to be in our state, and talking about what the changes in infrastructure that was necessary to move our system forward. And so we're really excited about the work that we've done in this space. It's been going on for about 5 years plus some change at this point. We have backed it up with some data studies already, are continuing to do that by performing a cost gap analysis on what it would really take to fund foundational public health services in Missouri. We expect that number to be fairly eye-watering, because we know what our current system's challenges are. We also know and have looked to some of the other states that have done some work in foundational public health services to move that forward. So we are working actively to build this system. We have had some bipartisan support for this. We will need a lot more to lift across the state. We're having some of the most successful conversations, though, with elected leaders across the spectrum about the consistent delivery of public health services, and the ability to do localized community engagement. Those tend to be popular topics, and we're dialing in towards that as much as we can. We aren't naive about this work. I think this was going to be a huge and difficult lift in our state last month. It is going to be a huge and difficult lift in our state next month. But we're pretty determined that this is our path forward to focusing on our public health system and its challenges, being realistic about what they are, but also some of the successes that we're delivering and what we're more capable of delivering to the public with some appropriate funding. So confusing national landscape, frankly, is just fueling our desire to help work on our context, and support our locals, and to make sure that that's a system that's functional. Next slide, please. By that, I really don't mean to indicate that we aren't affected or concerned by the national conversations. We are. It makes our education harder. It makes communication and engagement with our communities more difficult. It makes the freedom to communicate politically a lot more complicated. And frankly, it's scary for many of the leaders who hear echoes of all of those conversations directly in their community, in the lobby of their departments, amongst their staff, etc. And is often taken by local leaders with an accompanying direct threat to their job. In public health, we very much believe in prevention. There are a lot of things that could be different, and the outcomes could be different if we all collectively did better at preventing a lot of things. And we may end up watching preventable conditions prevail in our community, and that's hard for us to do, especially outbreaks. And it's not hard not to be frustrated about that. And I don't think any of us really know how the national funding picture is going to shake out at this point. But we expect it to be complicated and uncertain. And uncertainty is the enemy of like consistent delivery of services and consistent communication. And that's a problem for us all, I think. And we are dealing with an increasing number of people who have ideological opposition to public health, like roles, to public health services, and to some of the science that we use to make decisions by. And that's been happening for a long time. And it is frankly been emboldened by the pandemic and the time periods that we've been dealing with ever since then. We expect that to continue. Not to be a giant bummer, however, if you go to the next slide, I do also want to talk about why I'm still relatively hopeful about where we are, particularly in Missouri and hopefully like across the country. One of the weird dichotomies in public health is that as a field, we're not always popular. A lot of people will say that they don't like public health, particularly having learned more about it relative to COVID. But the majority of the services that we deliver to the public have historically been fairly popular. People do want to know that the restaurants they eat in are healthy and safe. They want to know that people are working on maternal child health. They want to know where to get travel vaccines or vaccines for children. They want clean water. They want clean air. They want lots of the things that public health delivers on a consistent basis. We're not always very good at communicating that to the public, and I think we can do a lot better about that. But people want to know that they can get connected to care. They want their health taken into consideration when there's an emergency. Like all of these are services that our public health system delivers. And frankly, they're relatively popular if we can make sure that the public remains familiar with what those are and how we're doing it. I think we have to be clear about our challenges in the system. We also need to be clear about our wins. And I'm not sure we're always very good at that part. Everyone that takes a vaccine is a win at this point. Everyone that comes to a local clinic because they're worried they may have been exposed to an STI. Every first-time mother with a high-risk pregnancy that gets connected to their first OBGYN. Every time we deliver oral sealants in schools to children to prevent dental caries is a win. And every single one of those needs to be taken as a public health win within this space. We are delivering services that are worthy of the public's trust, and they're worthy of the investment of public dollars. And we just have to keep saying that in as many places as possible. Living in a complicated political environment has made me cautious in a lot of ways, but hopeful about the stuff that we can still accomplish together. I think public health as a field has endured a lot. There's been changes, there's been setbacks, there's been funding cycle shifts in public perception. The system has always been wobbly, but stands and needs to continue to endure, I think, in that space. I do have a call to action to all of you here, I think, within this space. In addition to whatever public health interest brought you to this webinar today, you are also most likely a local resident of a public health jurisdiction somewhere. When I worry about the national picture, there are always things that we can do to try to make our voices heard in that space. But if you're really worried about how public health is doing, I also encourage you to get engaged locally. Go fight for a budget increase for your local health department. Find out who's on your board of health, whether they're supporting your ideas about what public health should be in your community. Ask your health department what they're doing in your community. Please help tell other people about that and spread that communication out wide. I think we're going to have to get grassroots and local in this space. I think it's been more of the environment that we've been working in for a long time in Missouri, and frankly, we intend to continue to do so. That's actually all. So I want to thank everybody and thank the network in particular for just giving me an opportunity to talk a little bit about the space that we've been in Missouri relative to this. And I'm going to turn this over to Anish.
Thank you so much, Spring. I really appreciated that presentation. As I was listening to you, I was just struck about the significant parallels between public health officials and election officials that we often work with quite closely at the Institute for Responsive Government. They both play such a pivotal role in community trust and both face such adversity in the wake of misinformation spread in 2020. I saw Molly mention in the chat about a bomb threat that was made during the Missouri State Public Health Conference, which is just unbelievable and so scary. And similarly, in the 2024 elections, unfortunately, we saw bomb threats in many jurisdictions. It's a lot to overcome, but as Spring was mentioning, the work on relationship building and community building that both public health and election officials have been doing have been making progress. And I'm very hopeful for a lot of that work that Spring was describing. So before I launch into the presentation, just a big thank you to all of you who work in public health, and a big thank you to all the election officials in the country who administered such a smooth and efficient election in the face of a lot of adversity. Next slide, please. Today, I had 4 things that I wanted to discuss. One was going through some 2024 election reflections. The second is talking about where the elections have left the political landscape, both at the federal and state level. Third, I wanted to talk a little bit about what we at the Institute are seeing as being on the docket, primarily at the state level and federal level, around voting rights and election bills going into 2025. And then lastly, I wanted to talk a little bit about some emerging work that a number of different groups are working on around effective governance and government administration reform. Next slide, please. So to begin, let's talk a little bit about the 2024 elections. I know this is hardly going to be the most energizing part of the presentation, but I want you to bear with me because I feel like it is important to reflect before we can start thinking about some of the next steps and what the work looks like going forward. Next slide, please. So this is definitely the season for hot takes, and I will caution both to take my remarks with a grain of salt, as well as the many hot takes that you've probably seen in the wake of the elections. I think the stories that we tell about elections are incredibly powerful. They can inspire and motivate people and inspire new coalitions to deliver change. But on the other hand, sometimes the stories we tell about elections can place blame and fear on already marginalized and vulnerable communities. And so I think it's important for us to reflect on what are the things we can learn from the 2024 elections? What are the things that have good data and evidence to back them up? And also to understand that it is unlikely that there is one explanatory factor that led to the election results, primarily at the presidential level, but also looking at the congressional and state level. And that a lot of these factors have to be taken sort of in isolation and looked at. Next slide, please. So the first thing I wanted to talk about is that obviously the United States does not exist in isolation, and there has been over the past year sort of a global anti-incumbency wave. As higher energy prices, higher food prices have made a lot of people's affordability much more challenging for day-to-day life. Incumbent governments, both on the right and left, have suffered pretty significant defeats and or lost significant vote share compared to the last general election in the past year. And here you can see that there are only a few countries, primarily countries where there were national security or significant crime issues that were sort of driving voter interest in electing the incumbent government, that were reelected. And in most countries across the globe, the incumbent government, in this case, just looking at the federal level, the Democrats faced significant loss of vote share. When looking at the United States in comparison to a lot of those other countries, the United States actually fared less in terms of that loss of vote share. But similarly faced some of those global trends that a lot of countries saw due to inflation, conflict, as well as other factors. Next slide, please. The other sort of takeaway that I think many have had after the election, and probably should have had well before that, is that demographics cannot be taken for granted. You cannot expect communities to always vote the same, and that political coalitions are always changing and shifting. There are many ways to look at the 2024 elections. If we have time in Q&A, we can talk about some of the others. I wanted to just share both a look at race and ethnicity and gender, as well as age, to some of the sort of shifts that sort of drove the 2024 election results. As you can see, there were some coalitions, including Black men, Black women, that remained relatively the same, though with some decrease for Black men and some increase in Black women, which also stayed consistent across men and women across race and ethnicity. Probably the biggest shift were for Latino men and Latina women, where you saw double-digit changes, particularly for Latino men compared to the 2020 election. And then with white men and white women remaining relatively static between 2020 and 2024. Next slide, please. When you look at age, there were shifts that both advantaged Trump across a few different age demographics, as well as advantage Harris for those who were 65 years or older. And similarly, these are not trends that necessarily existed before 2016. So some of these are defying trends that you saw between 2008 and 2016 before Trump was a candidate for the general election for the presidency. But as you can see, for younger voters, a double-digit shift away from the Democrats towards electing or to voting for Trump. Whereas for those who are older, a slow shift away from Trump and a virtual tie between the two candidates. I think the other thing, which I did not include on this slide, that I would encourage, and I can share a link about this later, is the geography of the impacts. If you look at battleground states, so the 7 battleground states, Harris actually improved on vote share compared to Biden between 2020 and 2024 in 4 of the 7 battleground states. The real story that made the difference for Trump was that he was able to substantially increase his vote share among newer or less likely to vote voters in those states. The popular vote, which I know surprised many, was really driven by the fact that the bottom fell out for the Democrats in heavily Democratic and moderately Democratic counties. So that would be in Kentucky, in California, New York, New Jersey, and other states like that. And I think there's some important lessons there that we can also talk about when we get to Q&A. Next slide, please. The last thing I wanted to mention is just the issues that sort of drove both voter participation as well as political opinion between the parties. Abortion was on the ballot in 11 states, and in 9 of the 11 states, voters decided to preserve or expand access to abortion, with 2 states, South Dakota and Florida, where voters voted down those ballot measures. I will note that in Florida, the majority still voted for the ballot measure, though they have a 60% threshold. Similarly, there were other issues like ranked choice voting that was on the ballot, which lost in most states, with the exception of Washington, D.C. As someone who works on voting rights and structural reform, I think it is not disheartening to hear that, because I think it is one of those things where anytime you're changing the voting system in a state, voters are going to look at that very critically, and there are no one-size-fits-all reforms when it comes to changing how we vote. In addition, obviously trans issues were something that was unfortunately made into a national debate. The same sort of vilification that we have seen for other marginalized groups playing out in played out for trans people in this election, where issues of bathrooms, which you have seen for when around gay rights fights, as well as segregation, became sort of at the national forefront over the last few years. And then finally, of course, immigration and the economy, with the economy being both driven by inflation as well as concern about economic policies. Next slide, please. Next, I want to talk a little bit about the political landscape. This, I think most people on this webinar have already seen, so I will just lightly touch on this and then certainly entertain any questions that folks have to dig in deeper. Next slide, please. As I'm sure everyone here knows, the House has remained in Republican control with a narrower sort of margin between the two, though pending 4 races that have not been called. The Senate results marked a shift to the GOP with more of a margin than I think many expected. And the Senate will be 45 Democrats with 2 independents who caucus with the Democrats and 53 Republicans. Next slide, please. The state level landscape is a little more complicated and did not follow the top of the ticket. One overall observation is that there are more split control states than there were prior to the 2024 election. That includes Michigan, Minnesota, and a couple other states. Supermajorities in some states were also broken, including North Carolina, which was a Republican supermajority, and Montana, which was also a Republican supermajority. And so those shifts were both to the left and right. And so on the state legislative level, there were different shifts that you saw in states that did not always track with the top of the ballot. Next slide, please. The next thing I want to talk about is really looking forward to legislative sessions, both at the state level in 2025, as well as the federal docket when it comes to democracy and voting rights issues. Next slide, please. There are 3 main issues that we're hearing from state legislatures across the country that are likely to be sort of prevailing fights going into 2025. The first is a relatively new issue area called that has come to the forefront mostly due to some misinformation during the 2024 elections, but also just primarily as sort of a new wave of legislation to make voter registration more challenging for communities. So proof of citizenship requirements for voter registration, we expect to see in almost every state, with Texas already seeing 5 versions of proof of citizenship requirements for voter registration dropping for the upcoming legislative session. At the federal level, the SAVE Act, which was already introduced in 2024, is likely to have sort of a Part 2 version introduced in the new Congress in 2025. It's important to note that the way that this debate is shaping is not intended to necessarily resolve an issue. It is more to add additional paperwork, additional requirements for people to present documentary proof of citizenship before they can register to vote. I think there will be some healthy debate in some states about additional list maintenance practices, as well as other protections that can be taken around this issue, but certainly the legislation we're anticipating seeing is likely to have an anti-voter bent to it. Similarly, voter ID laws will continue to be a focus in states. These we've seen year after year at the state and federal level. The distinction being at the federal level with a Republican trifecta, there's more likely to be energy and movement on federal requirements for voter ID. And while voter ID can be administered in an accessible manner, there's sort of common sense reforms that can be considered. A lot of the legislation that's often debated is restrictive in the types of voter ID permitted to be used, signaling out or leaving out types of voter ID that are often used by communities, such as college ID, as well as others. And then the last sort of overall area, which we have not seen as much in past elections or past sessions, is the federalization of elections and political activity. This, I think, is incredibly worrying as sort of a new sphere of the fight about democracy and voting rights, where we are concerned that with one-party control of the federal government, there will be legislation which would federalize control over elections. As many of you know, elections are administered primarily at the local level, currently in the United States. And there appears to be momentum and energy in Congress, at least currently, around the idea that the federal government should play a more central role in the administration of elections. While that can be done responsibly, I think there are legitimate reasons to be concerned that the legislation that would be advancing this under the current political balance is unlikely to be handled responsibly. The other issue I would mention is just there is legislation currently introduced to go after nonprofits and sort of far-reaching revisions to election codes around issues like vote by mail, ballot drop boxes, election reporting, and more. Next slide, please. So moving from the state and federal landscape around voting rights and democracy, I want to talk a little bit about sort of the work around governance across the country. When we think about why, what sort of motivates people to vote and what people's experience is with government and with government services, there's a lot of opportunities for us to make progress at the state and local level around ideas that can make sure that people are receiving the government services and benefits that they deserve, and also making sure that people are experiencing models of governance that engender trust and engender interest in wanting to participate in our democracy. Next slide, please. So there are three overall ideas that I think at the Institute for Responsive Government, we have been interested in working with other partners, as well as states who are sort of developing their agendas going into 2025. One is really an idea that government is, at its core, an entity that's focused on customer service. And a government with a customer service orientation really shows its values, the needs of its citizens in its day-to-day operation. And by being responsive, transparent, and efficient in its interactions, government agencies can foster a sense of respect and accountability, which in turn strengthens public trust. Similarly, when government fails to be able to administer benefits and services in a way that people expect, that can leave people feeling like government does not care or does not have its best interests at heart. The second is around data sharing, and this is something that I think is something that has to be handled incredibly carefully. The US has a decentralized information system with local, state, and federal governments selectively sharing data with each other. And in many ways, this is, I think, a valuable byproduct of US federalism. Centralization of data sharing and information can come with a lot of risks. That being said, there is significant room for improvement around the way that data is shared to facilitate enrollment, facilitate access to services, and to make sure that people are getting the support that they need when they need it. And addressing some of those high impact areas where data sharing can provide constituents with better service, while certainly taking a very close look at data privacy can help remove the sort of common pain point for people being able to navigate government services. And the last is addressing critical needs. This is not, I think, something that will shock many people, but when government effectively addresses critical needs such as healthcare, housing, or disaster relief, it really shows people that government is a place where you can come to be able to solve big problems. And the success in being able to address those critical needs builds public confidence in that capacity to solve those pressing issues. So when we come to elections, when we come to candidates discussing sort of policy platforms, it is incumbent on us to have effective governance before we're able to bring people to the table around progressive policy solutions that require a significant role for government. Next slide, please. a few of the areas that I know many groups and many officials here on this webinar are thinking about. One is protecting and expanding healthcare. Certainly the federal government, many of the candidates, both at the congressional level, at the House and Senate, have made clear that Medicaid is one of the healthcare programs that's on the docket, and is likely to be a key focus for the new administration. As those new directives come around Medicaid as well as other healthcare programs, navigating effective implementation of those that minimize the harm and sort of help make sure that people are protected at the state and local level will be one of the most sort of valuable contributions to that state and local governments can do over the next 2 to 4 years. Access to identification both is a key part of our ability to make sure that constituents have access to services and benefits as well as employment, and is also something that government plays a significant role in making sure that people, their constituents can easily obtain identification. There are new reforms like mobile ID, digital ID, as well as making sure that people who are experiencing a significant life transition, such as those returning from incarceration, are provided identification in a seamless way that allows them to make sure that they're able to navigate both employment, healthcare, and housing changes that they're going to be going through. And the last is cutting red tape. While there are many important protections and regulations, there are also day-to-day experiences that most people have with government that can be kind of a nightmare. I know from my own experience, applying for permits or applying for licenses, those processes can often feel like you're engaging with a black box on the other end. And the ability to have government that cultivates transparency, accessibility, and efficiency in those processes are some of the small touch points that over time can start to also build confidence and build trust in government. And these are things that a lot of states are experimenting with. Pennsylvania recently had a reform effort around permitting reform that had a lot of incredible results just from a few simple changes and around data collection, transparency, and then accountability for how long people needed to wait before hearing a response from local or state government. There's many more and lots of good ideas that I think many of the folks here on this webinar would love to stay in touch with many of you after this, but just want to talk a little bit about some of the pathways to progress over the next 2 to 4 years that are not as impacted by the election and sort of provide a way to make progress on a lot of the issues that we care deeply about. Thank you, and I'll hand it back to you, Darlene.
That was great. Thank you, Kayleen. Yeah, come on screen, speakers, Spring, please. I hope what folks were able to hear is lots of noise at the federal level all around us, right? And lots of state and local opportunity. We've heard a really specific example in Missouri about how they've been dealing with this for a really long time. And lots of thanks and shout outs to Missouri for all of the work you guys have been doing. It sounds like there's a lot for the rest of us to learn from your experience. I think we're not going to be able to get to all the questions, but I think one of the things I wanted to do here was, I think there's like one broad question in the Q&A that I think maybe we'll do a quick round robin for each person and then address maybe a few specific questions. So I think the sort of like broad-based question is about this approach to policy work and sort of the sort of idea of the high road of, you know, when they go low, we go high. Should there be a new type of approach? And this person says, when they go low, we go low too. Sort of changing rules and how to us being the only ones obeying the rules. I'd love to hear maybe a round robin sort of thought on that particular question. Should we be using a different approach, and that approach in particular? Whoever wants to go at it first.
I'm happy to. I think there was a book I read last year that I imagine many of you might be familiar with, but if you haven't, I would encourage you to read, called Recoding America, where it talked a little bit about this idea of like a procedural fetishism around the left, where we feel like we need to follow everything step by step in the process outlined, rather than thinking about the big picture and sort of the overall outcomes that we want to achieve. And I think I do not subscribe to the idea that when they go low, we go low. I think I do not want to take the lessons learned for my tactics and strategies from those that don't share the same values. But I do think that there is something about how we are oriented around effectiveness and making sure that our sort of goal is not to just be mired in ideology, in steps that we think will have been done before us and should continue to be done, but much more about what are the impacts that we're having on people's lives? What are we doing to help vulnerable and marginalized communities? And how are we building effective governance in a way that allows people to feel like government is there to take care of them and is there with solutions that have a meaningful impact on their life? So it's just an initial reflection on that.
I can jump in. I think it's more complicated than just sort of going high or going low or anything along those lines. I think there are voices we need to listen to. And sometimes I think there are voices we need to have heard, but not address. There are lots of people who have shouted lots of things at me in a variety of public forums. And it, like, not all of I think my responsibility as a government official often was to hear them, but not necessarily to respond to all of them, but to understand the place that people are coming from and how they feel about it, and that's real and in the moment for them, but also to have more of a handle on how the broader public feels, how the people who I'm delivering services to feel, what my responsibilities are, even when they're not popular, within those spaces, and to take the rest of that into consideration when I make my decisions. I think if I changed all of my decisions based on things that people screamed at me at various points in time, like I would have made very different decisions. I don't think I think we can over ascribe the entire public's opinion to the loudest possible like presenters of it. And I just don't agree, even when they're elected officials. I just don't think that's true.
Yeah, and to jump off of both what Spring and Ashish were saying, I don't think it's really a question of going high or going low. Really the lessons that I'm learning about everything that's happened during this election cycle and after, is that we need to be better at telling effective, clear stories, and we need to be better at elevating stories from folks who are impacted by the policy choices. I know in public health, coming from someone with a doctorate who has worked in public health now for a number of years, we often get bogged down by the data and evidence and the nitty-gritty policy details. And that's important, I think, for folks who are making technocratic decisions about our field, and really important to understand the nuances of those policies. But those nitty-gritty details are not effective communication strategies. And we have to be better as a field about talking about the real life implications of public health and health equity work if we want folks to show up to protect public health, to be partners with us in this work. We really have to be more effective organizers in a sense.
Thanks, everybody. And we actually are sort of at time, and so I'm going to stop there. And it also actually stops me from asking some of the nitty-gritty questions that we got to or that we have. So thank you, Nora, for making clear one thing that we can do as a field. With that, I am going to say thank you one last time to Spring, Nora, and Ashish, and then hand it back over to Kayleen to close us out with just some other last minute things. So thank you. Kayleen, do you want to go to slides or are you okay ending things here? Call it done. All right. Well,
Sorry.
thank you all. That's okay. Go ahead, Kayleen.
Yeah, sorry, I was on mute. Thank you to our panelists and attendees. I just want to remind everyone that you will receive an email when we post the slides and the recording of this webinar to our website. I also want to invite you to join us at the 2025 Public Health Law Conference, where there will be additional sessions exploring further public health authority and systems. And that concludes today's webinar.